Welcome, everyone, again. I'm Dr. Bernard Ho, Vice Chair of Canadian Doctors for Medicare, and we're grateful to have all of you here with us tonight. I want to first get started with a land acknowledgement. While we are meeting virtually, the CDM office is located on the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and the Mississaugas of the Credit. Toronto is within the lands protected by the Dish with One Spoon Agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. This agreement captures our responsibility not only to the land, but to one another as well. I encourage you to reflect on the responsibilities and relations of the place where you are joining from. At CDM, we recognize the disproportionate and unjust disparities that Indigenous peoples continue to face today due to racism and the ongoing effects of colonialism. At CDM, we are committed to working to reduce these inequities as part of our work to advocate for better Medicare. And before we begin, a few housekeeping matters. This webinar is being recorded so that it can be shared with those who couldn't join us this evening. Please feel free to send chat messages to attendees in the chat box. We'd love to hear from you too, so let us know where you are from and why this is important to you. You can ask questions at any time through the Q&A function, and we'll try to get through as many as we can. And closed captioning is available and can be turned on. This event will run until 9:15 p.m. Eastern Time. And again, I want to thank all of you for sharing your evening with us. Now, to begin the webinar, we are so thrilled to welcome Dr. William Hsiao, who led the task force that designed Taiwan's healthcare system. Dr. Hsiao will discuss why he chose Canada's single-payer system as the initial blueprint for Taiwan, how Taiwan has built on and improved that model, and what lessons we can learn. Dr. Hsiao is the KT Lee Professor of Economics Emeritus at the Harvard T.H. Chan School of Public Health. He earned his PhD in economics from Harvard University and is also a fully qualified actuary with extensive experience in both private and social health insurance systems. He became a leading global expert on single-payer health systems in recent years. Recognized as a leading global authority on national health system reform, Professor Hsiao combines economic theory with empirical research to craft innovative solutions. He has helped design universal health insurance programs in countries including the United States, China, Taiwan, Colombia, Malaysia, Vietnam, Hong Kong, Sweden, Cyprus, Uganda, and South Africa. And without further ado, I'm going to pass it to Professor Hsiao.
Thank you, Bernard. I appreciate this opportunity to speak to all of you, and I want to say my greetings, and I'm honored to have a chance to share some of my history as well as some of my current observations with you. You're welcome to interrupt me anytime if you want to raise questions or even objections, okay? So let's keep this informal. And as Bernard said, 35 years ago, Taiwan asked me to lead a team to design a new health systems for Taiwan. At that time, Taiwan had 20 million people. And we look around the world, see which country has the best system, and Canada was selected. So we studied the Canadian system, which you actually began the reform in the early 70s, but then formalized in 1984 through legislation. We really admire what Canada had done and emulate, let's just be honest, trying to actually copy what you have done. And then we're also then trying to go beyond what Canada has done some, and I will explain that in my presentation. So in today's talk, I would like to, because I assume most of you do not know about Taiwan. Taiwan is a society and also its health system. So I have to bore you by giving you a description first so you can understand the reference point. Now I'm going to compare the similarities and the differences between the two health systems between Canada and Taiwan, and then look at the performance of these two places. Then ask the question, what's the root cause for the difference in performance? And I hope through that examination and analysis with you, all of us can gain a better understanding what both what Taiwan can do, what Canada can do to improve the health systems of both countries. So that's the intent of my session. So without further ado, let me begin with the first slide. Bernard, please. Taiwan, this is the latest data. You can see Taiwan only have 60% of the population, but the age of the population, elderly people over age 65, the two countries are similar. Why that's important? That's because Asian people have particular health problems and also more complicated problems and more frequent visits and surgery and so forth. So I want to put that aside to say the two places are quite similar in that regard. While Taiwan only have 60% of the population of Canada, you can see Taiwan's land size is less than 1% of Canada. So that's a big difference when we're trying to do the analysis and comparison. And on the right-hand side of the slide, I show you Taiwan as an island, but actually two-thirds of it is mountainous. Only around the coast are flatlands. And the tallest mountain that runs through Taiwan is about 12,000 feet. That means 4,000 uh, kilometers. The GDP per capita of Taiwan is about 80% of Canadians. So they are not economically, they are not as advanced in average as Canada, although their computer, particular production of the chips, is one of the most advanced in the world. Then if you look at the health spending, Taiwan spends only about half as much as Canadians per person. However, that's not a fair comparison. We have to compare with the GDP. Taiwan basically is spending about 70% of its GDP compared to Canada. That is 70% of Canadian spending, which is 11% Taiwan is spending, in round numbers, 8%. So Taiwan is spending less money and less percentage of its GDP, because all of that going to be important background information for our discussion and your questions. Next slide, please.
Professor Hsiao, we have a question from the audience. Would you like to take that now or afterwards?
Okay, let's take it now.
Okay, Heidi, go ahead.
Heidi, go ahead.
Oh,
Hello?
sorry, I don't, can you hear me?
Yeah, we can
Yes.
hear you.
Oh, I'm sorry. I put my hand up by accident. I am enjoying it, but I didn't mean to interrupt. Sorry about that.
Okay, no worries.
Okay. Then may I go to the next slide?
Yeah.
Here, I'm sorry, I have to give you a lot of details. You don't have to remember or know all of them, but I want to tell you in financing healthcare, when we look at a health system, we first to look at to see where did the money come from, because money is the mother milk of healthcare. And that's where we actually emulated and copied what Canada did for Taiwan. That is to have a universal coverage of healthcare and through a social insurance system. So using Canadians' terms is you have a single payer universal health insurance system, Medicare. We're trying to copy that. That's how it's financed is coming from taxation and the premium paid by the employer employees. But there is a slight difference. We also ask patients to pay a small amount of copayment. I will come back to that in a minute. Okay. Canada makes it totally free. Uh, for Taiwan, for different reasons, we did not. Then, in terms of what services are covered, that's the second item. For Taiwan, we decided to for comprehensive coverage. That's covered not only outpatient hospitalization, we also cover drugs for everyone, dental, eye care, hearing, and even the nursing for long-term care for patients who are homebound. But as I said earlier, there's a slight difference. We ask people to pay a small amount copay when they go for visits or hospitalization. For a visit, for example, right now they pay basically $5 per visit, but the amount they have to pay is capped annually to make sure that does not create a financial stress on the people. So that's a slight difference from the Canadian system. In terms of healthcare delivery, basically Taiwan and Canada are similar. Hospitals are provided by public, nonprofit, and private hospitals. But let me just say, Taiwan's public hospitals are relatively fewer, and it was not very well run and managed. Actually, a nonprofit hospital by charitable organizations blossomed. So today, actually, most of the services are provided by the nonprofits with tertiary care provided by the public. There are 2 or 3 different centers in Taiwan. For outpatient, physicians are practicing on their own in their own clinics, but also a large portion of the outpatient services are provided by hospital outpatient clinics. And here I'm not familiar with the Canadian system, whether how much of the outpatient are provided by the outpatient clinics, but I assume the specialists are really based in the hospital and their outpatient do come from the outpatient clinics. And so CT and MRI tests are provided by hospitals in Taiwan rather than freestanding clinics. And drugs are provided by hospital pharmacies. And so the healthcare delivery are quite similar in terms of system structure between between Canada and Taiwan. Also, the payment system to the providers, that's to the hospitals, doctors, and pharmacies, they are also quite similar. Before, they were all paid by fee-for-service, but both places recognize actually that's inflationary. So for hospitals trying to shift to a DRG payment, but usually hospitals resist that. It takes decades before a country can shift fee-for-service payment system to a DRG or episodic payment system. But I don't need to go into detail with you. Then finally, there is a major difference between Taiwan and Canada. In Taiwan, the policy and procedures are centralized. Although it's administered through 5, 6 different districts, they divide Taiwan into different regions, and each region has some flexibility to interpret the policy. But Taiwan is quite uniform in the administration and management of healthcare. But there's a major difference between the two countries, as far as I know. Actually, we learned from Canada. We went to Canada and learned from British Columbia that at that time, they were developing a uniform clinical information system. We realized how important that was, and we actually developed that for the whole Taiwan. And then later on, digitized it. And that uniform single clinical information system is used by every doctor, every hospital, every pharmacy. But that clinical information system then became the management information system for management, for record keeping, to how do you code your services, what information you have to provide. That's all uniform throughout Taiwan, and my understanding is Canada does not have this unified information system. You can correct me where I say something incorrectly. Okay. If no other objections, I will go to the next slide. I just finished giving you the background of Taiwan as a society and also its healthcare system compared it with Canada, then let me just actually summarize where they are similar, where they are different. And this can go very quickly. Both have a single payer. In the world, Canada is considered the forefather of single payer social health insurance system. And we emulated that from Canada. Okay? Health services are delivered not only by public, but it's delivered by nonprofit and and for-profit organizations. Let me just tell you, these different type of organizations have different objectives and motivations. So they behave differently on their efficiency of the operation, as the quality of care, and also how they treat their employees. So don't glide lightly when you just read, oh, they are for public institution or they're for-profit institution or not, they're nonprofit. Their behavior, organizational behavior are very different. The third similarity is that both societies and countries provided use fee-for-service as a payment, but later on trying to change it. Change it to DRGs, and of course, Canada, every province is different, but my knowledge, if that may be wrong, at least most of your provinces have a global budget decided prospectively. So that's the similarities. But then there are differences. When we do the comparative analysis, we should recognize the countries have different culture, different social norms. So we should not just blindly say, oh, they're the same. I just want to remind you that, for example, for elderly care, Taiwanese believe wherever possible, the younger generations are trying to take care of the elderly. So that if they're staying at home, you actually should take over a major responsibility to go shopping for them, to uh, to visit often, or to do cooking. Okay? But Taiwan also have a very unique history. That's the influence of Japanese. Taiwan was a colony of Japan from 1895 through 1945. Japan's medical practice was adopted and penetrated Taiwan. That is, every office visit is very short. I want to alert you, the average office visit in Japan and Taiwan is maybe only 5 to 8 minutes most. Unlike in Canada, it's 15 to 20 minutes. Consequently, patients go to doctors' outpatient clinics usually on average 15 times per year. In Canada, it's only 6 times. So there's a big difference there. I want to alert you on that. That's the difference. But second part, I think the two societies are different is Taiwan does not try to give a tight control on number of physicians who can migrate to Taiwan or new medical schools get set up, nor control tightly the new investments hospitals make, let's say in new procedures and new equipment like MRI. My understanding is Canada has much tighter control. So again, I could be wrong. Then the third difference is what I said is Taiwan is centralized throughout the whole society, but Canada, you have a social compact between the federal government and the provincial government, but each provincial government could have very different payment system, whether they will provide drug coverage or not, and how they will deliver the health care. Taiwan doesn't have that difference. And then last but not least, I just want to highlight again, Taiwan's Medicare has comprehensive coverage of all services, much more than the federal specifications. And I mentioned already in Taiwan, it covers drugs, besides hospital and physician services, tests, drugs, dental, eye care, hearing, and so forth. Okay. So just bear in mind when we start analyzing why the two places come up with different performances. Let's look at their performance rather than inputs. Inputs doesn't necessarily produce better health care or better health outcomes. So as an economist, we're always only trying to look at how a system is structured and how much resources does it use, and then look at the outcome. The outcome here, I just summarized four of them. You can add your own. One is input, that's amount of money input. Taiwan spent 6 to 7% of its, 7.8%. I changed that figure because I tried to verify the latest figure and I got the 7.8%. Canada is 11 to 12%. Insurance coverage, Taiwan basically has everything covered. To implement the universality, the National Health Insurance Administration even organized teams to go to the homeless people living along railroad tracks and bridges to enroll them and to educate them. They can now get nearly free health care. Well, Canada also have universal, and I don't know how you implement that universality, but I know how hard you do to enroll and cover the health services in your territories. Canada is a huge country, and so it's I started working in Canada, by the way. I was invited by your Ontario government and other provincial governments in the 70s. So I've been there many times, besides as a tourist. The life expectancy of the two places are similar, both about 81 years old, and Canada maybe 1 year longer. Infant mortality, surprisingly, Taiwan is better than Canada. And I don't know the reason why. I don't know if it's due to vaccination or because you have such a vast territory, low density population in some areas. To vaccinate or take care of the maternal child health is much more difficult. Okay, that's the out performance. Then let me uh, overall the big picture. Let me go to the next one, which is more publicized at the personal level. That's waiting time. Canadians are concerned about the waiting time. So is Americans. So is Taiwanese. Here's a comparison. Basically, I can summarize for you is Taiwan for health services, there's no wait. For outpatient, you can actually get the same day service, just walking in an outpatient clinic or a doctor's office. The average wait maybe is a day or two. You can see in Canada, the data is 2 to 7 days. Then usually we look at the elective surgery like knee replacement. Taiwan's wait is 2 to 6 weeks. Canada is 3 to 6 months. And that's quite much longer. The other comparison we usually do in international comparisons is how long do patients have to wait to initiate cancer treatment once they're diagnosed? They are diagnosed they have cancer. The two countries are quite similar. It's just a couple weeks or a few weeks, okay? There's not much difference. But then if you look at the CT scan MRI, Canada and Taiwan are vastly different. So you have to ask, why? The overall picture, the previous slide showed Taiwan spent less. Only 70% of the Canadians, what Canadians spend from their GDP. Canada spends 11 to 12%. Taiwan spends, let's say, 8%. Personal level, the waiting time. Taiwan basically does not have a waiting time problem. If anything, it's made it too easy for people. That's why, on average, the Taiwanese see their physician 15 times per year. That's the average. Some of them go to see a doctor every day, really abusing the system. They have all the records. So that's the difference on the performance. So here I like to pause and ask you, what do you think is the root cause for the differences in the outcomes? I mean, in the performance of the two places. Earlier, I know I went through very quickly what are the similar, what's the difference, but you are all of you who are on this webinar must be interested in the subject. You must have some opinion of your own. I'd like to hear from you. What do you think are the root causes?
I think we have one person, Catherine, who might want to share an answer. Catherine, go ahead. Just unmute yourself, please.
Okay. It struck me that there were two big differences. One is perhaps the Canadian system is more inefficient because we don't have one management system for the whole of Canada. We have different rules. We don't even have cross-border, uh, privileges for the health providers that we have. And the other big difference I saw is that Canada limits the health providers. I don't know if you've got any statistics on the number of health providers per citizen in the country, which might tell us whether or not, that Canada, does have a lot of rules about the number of health providers and even how many health professionals we graduate.
Catherine, I can answer your first question. To prepare this webinar, I looked up the information. The public information says Canada has 2.7 physicians per thousand residents, 2.7 physicians in active clinical practice for every 10,000 residents. In Taiwan, the number is 2.3. So Taiwan has less. In terms of hospital beds, actually, Canada has more beds also per thousand people. So is
Is it 2.7 active physicians per thousand residents?
right.
Okay. Hmm.
You can check nowadays with the AI and Google, you can verify this kind of information to make sure I got it right. But uh, so, but your initial reasoning is correct.
I was thinking too that it's so much more expensive to have each province develop its own um, codes and its own way of managing the system and its the each one is duplicating what the other is doing. Not identical, but they still have to go through the process of running a system that collects and it's not only a management system, it's a health data system as well. And so it would be seems to me it would be a lot more efficient to run one national one.
Mm-hmm. Uh, your reasoning is correct. There's duplication. Uh, but however, if I have to defend Canada, I would say Canada is so big, and we have to have really let each region, each province and territory to de to do their own thing. But the question is, a lot of other th administrative practices, including coding, could that be standardized by the federal government? But that requires the provincial government to agree to it. So,
Yes, but for example, in an earlier meeting of this same organization, there was one doctor working in a remote area, and I think he required like 5 licenses. And he had to renew them every year because he was flying into remote communities. So he was providing a very valuable service, but there was an inefficiency there that he had to be licensed in each jurisdiction.
That's an excellent example. And I actually going to come back to that. I believe I will offer some other evidence, at least incidents I encounter in Canada, which the decentralized system creates really inefficiency, you might say, paperwork for the
Thanks very
provider.
much for sharing that, Catherine. I wish I had CDM swag to give you. I would suggest in the interest of time that we should move on, Professor Hsiao. I want to make sure we get to the Q&A, and we have quite a few questions from the audience.
Okay. Thank you.
Then let me offer you my hypothesis. So don't take this as the truth. Next slide. Don't take this as a truth, but this is just a tentative hypothesis I'm offering. I consider the waiting time Canada has is you have a mismatch between the demand and supply side. And the government's policy to limit number of physicians, nurses, and the capital investment have not considered adequately the demand side factors. I worked with Bob Evans at the University of British Columbia very closely for almost 2 decades. I wish I posed a question to him when he was still had such a sharp mind. But obviously, your physicians are busy. Your hospital beds are filled. So but meanwhile, the waiting time is so long. So it tells economists like myself is your supply side is not meeting the demand. Why? Well, I do know Canadian government actually regulates that. There could be good reasons. Let me tell you, in earlier decades, there was a big debate among policymakers. That is, if you increase the supply side, the expenditures will just increase. There's a slogan called, every bed built is filled, because physicians can induce demand. That theory came from Bob Evans, your Canadian, and he proved it. And we found that's true throughout the world. Consequently, many countries then trying to control the number of doctors, hospital beds, and MRIs to make sure their health expenditures do not accelerate too fast. Here is the only hypothesis I'm advancing. Another reason I would say is the payment system. Let me offer 2 examples. Canada used to give your hospitals a prospective budget. The budget then is a global budget. The hospital can have flexibility how to use the money, but the hospitals were required to produce so many hospital days of service. That's the inpatient services. Consequently, economists like myself have analyzed Canada with Bob Evans, found you have one of the longest average length of stay among the OECD countries. That's how a payment system can affect the behavior of organizations like hospital. Because the longer the most expenditure per patient incurs during the first few days of hospitalization. After that is convalescing under observation. That cost drops by, I have done this kind of study in the United States, that cost drops to half to the earlier days of hospitalization. So if you're a hospital manager, you give me a global budget, but you require me to produce so many hospital days, I'm going to keep my patients in there longer than discharge them. Also, the second example I like to give is your physician's fees, you continue to pay for fee for service. So to generate the revenue, physicians, if it's the private practicing physicians, have to bring in more patients. And you worry about then how many physicians are competing with you, how many new doctors will there be coming in, which may take away a portion of your patients. And Taiwan set up a separate global budget for all outpatient services to protect, so doctors will not try to actually know if there's a fixed pot pie protected for them. Hospitals could not take it. Canada doesn't have that. When you use the market, which Canada and Taiwan both use the market to deliver the health service and allocate resources, the payment system is very powerful and sensitive. I question Canadian provincial governments really doing the right thing in many provinces. Third is Canada does not have a unified digital clinical and administrative record. Consequently, you are duplicating services. In Taiwan, wherever you go, right away the physician or the nurse practitioner or the specialist can tap right into your digital record. Know when you had a CT scan before, X-ray, what diagnosis it was made, what drugs you're taking. Canada doesn't have that. That means doctors have to spend a lot more time with patients, particularly when patients go across provincial lines. And then you also, to control the unnecessary usage, your provincial government, from little I understand, require doctors to do a lot of paperwork to explain and justify what you have done for the patient. Consequently, doctors are spending more time on paperwork than the Taiwanese doctors. That's the efficiency question. That's because you don't have unified digital clinical medical records or administrative records. Then the last but least is what Catherine, you also suggest maybe the decentralized system caused some inefficiency. Now I'd like to hear some rebuttals during Q&A period, okay? Then let me move on to give you what I consider really a worrisome thing. Next
Professor
slide,
Hsiao,
please.
we
Yes.
have quite a few questions in the Q&A chat. Would you like to take them now, or would you like to finish your presentation?
I just have two more slides. I'm done.
Okay, perfect.
I just have one point. That's all. I want to alert all of you, both Taiwan and Canada are facing a fundamental crossroad. Taiwan already traveled on that different road already. Both society and nations intended to provide one-tier health care for all. If you are rich, if you can buy private insurance or get concierge service, I don't want to permit that. I don't want to encourage that. I want everyone to have the same quality and the easy access to health care. But both systems are underfunded. That's the other commonality. Both Taiwanese and Canadians seem to be reluctant to pay more taxes or premium. And in my view, actually, both places could actually improve some of the efficiency first also, okay? Then that question, if people don't want to pay, but some people want better service, shorter waiting time, then are you going to allow them to have it? Taiwan already allowed that. Left a loophole, let doctors and hospitals do charge patients extra beyond what the national health insurance will pay. So the private hospitals in Taiwan live on that. They collect from the national health insurance as well as they add another charge. They create a two-tier system already. 30% of Taiwanese are getting the upper tier, but 70% are very happy with what they have and what they have to pay. Consequently, in my recent visit to Taiwan, I cannot find any political pressure to correct that, to maintain a one-tier system. Canada, I want to say, you face with the same problem. You are debating now, and some provinces are really going to open up for private insurance and private practice. They will create a two-tier system that will actually compromise one of the most strong and fair, equitable aspect of your healthcare. So, last slide, please. Last slide, I just want to say I will offer three potential lessons I have some confidence in. One is Canada can introduce unified clinical record system and management information system. That will actually, I will give you even an estimate. that will reduce your cost by 8 to 10%, because I do that kind of work in different countries. Also, Canada can reduce its average length of stay in hospitals. Right now, you have reduced it by shifting to DRG, but DRG was based on a previous very lengthy hospital stay. You can correct that. If you compare the average length of stay in Canada compared to all the OECD countries, you are the highest. And then last but least, I think is the government should re-examine how to balance the human resources you need in physicians, nurses, and capital equipment to match the demand. Thank you very much for your attention, and I appreciate this opportunity to give you my view. And I hope you don't take what I say as absolute truth, but I hope to stimulate you to think about it. And you can draw your own conclusions. Okay? Thank you.
Thank you very much for that presentation, Professor Hsiao. It was very insightful. I want to make sure we have enough time for as many questions as we can. We have quite a few in the Q&A. So I'll get started if that's okay.
Please.
The first question is from Paul. Once a patient reaches their annual cap, is the difference made up by the government, or is the practitioner or hospital required to absorb the cost?
The government pays, not by the providers.
Great, perfect. The second question from Hassan. Who decides on the rate of reimbursement for different services?
The government does that in consultation with the providers, and Taiwan also has a very imperfect system. They rely on the fees that physicians and hospitals used to charge. And rather than, for example, hospitals can do cost accounting, actually measure how much it costs them to provide the service. Then you can base the charges on that. But Taiwan does not do that. And Taiwan probably have to move towards some of that. But usually hospitals strongly object to that. Then you have information how well they are managing the hospitals. If you know, by the way, United States have done that kind of study for the same service, let's say appendectomy without complication. The neighborhood, in the same city, medium-sized city, the cost could vary 3 times. That tells you something about hospital management capabilities, how that vary.
Great, thank you. The next question is from Gerald. Are they using US CMS developed DRGs in Taiwan, or do they develop their own DRGs?
They use the same method but develop their own DRGs.
Next
Most
question.
countries adopting DRGs actually try to improve on it. I was involved a little bit in evaluating DRGs. I can tell you US DRGs can be improved. The development of DRGs can be improved.
I guess just to expand on that, in what way do you think they can be improved in the US?
For example, The DRG, the length of stay, or how long does the operating, uh, let's say for knee replacement, you use let's say uh, the time in the in your hospitals, uh, clinical, I mean, operating room record. However, you can standardize that because some surgeons are very slow. You actually, or they could be because they become very old. You want to standardize some of these clinical practices rather than just let the physicians have the autonomy if they want to stay on to do surgery even into their 70s, they can. In most countries, physicians can stay as long as they want to in their occupation.
Great, thank you. The next question from Matthew. Any reason why Taiwan's system is funded significantly by employer-employee contributions, whereas Canada is only from tax revenue?
That was partly for political reasons. The government's revenue from tax collection were limited, and Taiwan's, we followed a principle, and we found that was politically acceptable politically when we designed the system 35 years ago for Taiwan. We found people say for healthcare, a third should come from the government, a third come from our employers, a third from the workers. That one-third rule was developed by International Labor Organization. And when we surveyed and interviewed the employers and the labor organizers, leaders in Taiwan, they saw that one-third rule is the best. So it was done for political reasons.
Okay, the next question from Jerry Lin. What percentage of physicians in Taiwan are primary care providers?
Gosh, previously I know, but I'm outdated. I have not looked up. Previously, this about 15 years ago, that figure was about 40%. But I think I'm outdated. I know I'm outdated.
Okay, no problem. Another question from Jerry Lin as well. The two countries' outcomes are different primarily because of the sorry, that's not just a comment. That the two countries' outcomes are different primarily because of the strong influence of for-profit medicine and organizations from the US, such as a huge border and the proximity. So we have another question from Gary. On a recent trip to Taiwan, I had some conversations with local champions of social prescribing. One difference that jumped out at me is Taiwan's combined Ministry of Health and Welfare, which enables a much broader approach to health and well-being and allows for outcome measures that place social health at an equal level to mental and physical health. Canadian jurisdictions all have separated these ministries. I saw this playing out in a very real way, with Taiwanese physicians confidently advocating directly with their ministry for the integration of interventions like social prescribing into their systems of care. Have you considered the importance to health outcomes of this breakdown of health and social silos in Taiwan?
I confess this is beyond my expertise, and I did not know there's social prescribing in Taiwan. And so he's educating me on on that.
Great job, Gary.
And I will look into it, and I'm not sure. I'm not sure exactly in specific terms what's social prescribing.
We can definitely follow up on that.
Yes.
The next question is, how do we effectively compare the health systems between Canada and Taiwan when there are so many other factors such as population density, cultural health practices, housing, prevalence of substance use, etc.?
I I I agree with that. However, by doing the comparison, you can isolate, maybe identify some areas you should pay more attention to it. That's where like my last slide saying, what's the potential lessons? For example, by comparing Taiwan with Canada, Canada doesn't have the unified clinical record system or management information system. Is there a reason other than maybe because it's decentralized? Could federal government make a great effort? And like I say, if you develop that, my prediction is you're going to reduce the health care costs in Canada by 8 to 10%. You can test my hypothesis, even just do it in one province.
An interesting hypothesis. The next question is, how does Taiwan counteract supply-induced demand while balancing wait times?
Taiwan doesn't do it as well as Canada. Taiwan actually uses, because with the unified clinical record system, it uses computer to screen services that could be questioned, could be duplicative or maybe unnecessary. Then they give to professionals, physicians, to actually look into the clinical record. And then these physicians are hired to do the job as on piecework basis. Then the most complicated cases that goes to a committee. In Canada, I'm only familiar with what Ontario does. Ontario turned these cases to the physician, the medical association that has an committee actually handle that. And we're trying to recommend that to Taiwan. We think there should be a professional self-monitoring and review mechanism like Canada. And but Taiwan did not adopt that.
Okay, we will probably take one or two more questions before we end for the night. The next question is, what is the opportunity cost or the total cost of training doctors since medical school? And what is the comparison of salaries between Canada and Taiwan?
I can answer the second question easier because I actually, to prepare the session, actually the salary is compared usually is what multiple to the average or the median salary, medium compensation to the physicians. I'm sorry, the medium level compensation to physicians rather than look at the extreme high or extremely low and adjust for the cost of living. And interestingly, I found Canadian doctors' earnings of the typical medium doctor's compensation is similar to Taiwanese. But Taiwanese doctors work longer hours. They work, including call times, they usually work 65, 70 hours a week. They see more patients. Each hour they could be seeing 10 patients short.
Thank you very much. We will unfortunately have to end the Q&A there just because of time. But for questions that we couldn't take live on this webinar, we will work to provide answers in a follow-up email along with the recording of the webinar. I want to again thank all of you so much for joining us tonight and for such an engaging conversation. I also want to especially thank Dr. Hsiao, not just for your participation in tonight's webinar, but also for all the work that you do to help us better understand these issues. If you are a medical student, resident, or a practicing or retired physician on the line and not yet a CDM member, please consider joining us today. And Zarif has put a link in the chat. For everyone else on the line, please consider signing up for our newsletter for future updates and invitations to events like this. There is strength in numbers, and it is only by coming together that we will be able to bring about real change. And we know that we have a lot of passionate and knowledgeable guests in the audience. And we look forward to working with you to strengthen and improve our public health system. So thank you all again, and I hope that everyone has a wonderful night.